Hello everyone, myself Dr. Prateek Garg. So today we are going to discuss about laryngeal infections. So let's start with the question. A child is presented with a history of pain during swallowing and noisy breathing. So let's point out what patient or the examiner want to mention. Patient is having pain during swallowing. It means whenever the child is trying to swallow something, he is feeling the pain. And breathing is having a sound, that is noisy breathing. So by looking at these 2 points, what we get to know is the pathology or some sort of obstruction is at the level of hypopharynx. How I can say that? The breathing is affected with a noisy sound and also the pain during swallowing. That means the pathology must be somewhere into the oropharynx or the hypopharynx. Okay. Now, examination showed a toxic tachypnic child. So patient is very much irritable, having a toxic anxious type of look, and tachypnic with the increased rate of breathing, and patient is having inspiratory stridor. Now look at this point, stridor are of two types. We all know inspiratory and expiratory. Whenever patient is having inspiratory stridor, that means pathology is somewhere at the level of above the glottis, or we can say at the level of supraglottis or the hypopharynx area, because patient trying to inspire the air, so that will produce a noisy sound. And expiratory stridor, that occurs whenever there is a pathology in the subglottic area, like tracheal stenosis, subglottis or cricoid cartilage stenosis, or some pathology in the trachea. Okay, so that will cause the expiratory stridor. And inspiratory stridor, it happens in a pathology in the supraglottic area, or the pathology just at the level of the vocal cords or above that. Okay. And patient is also having drooling of saliva, which means patient can't swallow his own saliva. That much painful the condition is. So saliva is getting drooled over. Okay. So what does these points suggest? I do have a basic idea by looking at these points that the pathology is affecting my swallowing movements as well as my breathing tube, we can say, or the breathing system, we can say. So what I can think of my pathology is at the level of oropharynx or hypopharynx, which can affect both the swallowing and the breathing. Now the X-ray soft tissue neck lateral view is shown. The question has asked is most probable diagnosis is. Now look at the question. We all know whenever we want to swallow something, the food we take, it goes into the mouth, then it enters into the oropharynx, and from there it goes into the hypopharynx. Okay, and from there you can see this opaque shadow. Okay, this opaque shadow is representing the esophagus. Okay, now the food will enter into the esophagus. So if patient is having pain during swallowing, that means my pathology is into this area. Okay, got it? Now look at the X-ray. This is my windpipe, or we can say laryngeal structure, okay, which is anterior to the esophagus. Now as in the X-ray we can see this edematous structure is there. Okay, what does it represent? The bone here shown is the, which bone is this? Hyoid bone, and we can see a thumb-like impression here. This is my epiglottis, which seems to be quite edematous, giving an appearance like a thumb. So it's a thumb sign. Okay, it is very much edematous. So if my epiglottis seems to be edematous, so epiglottis is an cap which can close both the larynx or the esophagus. So whenever there is a pathology in the epiglottis, so my swallowing will be painful and plus breathing pattern will be noisy, or we can say the inspiratory stridor will be there. So by looking at the options and the given examination point by the examiner, so my most probable diagnosis seems to be acute epiglottitis. So it seems to be correct answer. Okay, I hope you everybody got it. Acute epiglottitis, because it's at the level of entry. It is at the level of supraglottis. That means at the entry level, if the epiglottis is being edematous, painful or inflamed, so patient while swallowing the food, if the food will touch to the epiglottis, the patient will feel lot of pain. And if breathing, because epiglottis is edematous, so patient can't breathe properly, so there will be noisy sound in the breathing. So looking at the question, my correct answer is epiglottitis. Now look at the other option. What do we mean by Crouch disease? Crohn's disease, it is also known as laryngotracheobronchitis. That means my inflammation is involving larynx plus trachea and plus the bronchus. So in Crohn's disease, patient will never have this toxic look because patient can breathe in, but there will be in the trachea or bronchus there will be inflammation, so wheezing sound will be there. If we palpate or auscultate at the level of the bronchus, we can have the wheezing, wheezing sounds. Okay, and patient will not have any pain during swallowing because the food can directly enter into the esophagus without going into the airway, because inflammation is below the level of the hypopharynx. So Crohn's disease will not be a correct answer. Now what are the other options? Retropharyngeal abscess and prevertebral abscess. We will discuss about these abscesses. One thing important, prevertebral abscess or the retropharyngeal abscess, these all abscesses, they occur into the various layer of the pharyngeal wall, and whenever there is an abscess, the patient will have either the lymph node palpable in the neck, or we can see in the posterior pharyngeal wall we can see a bulge. Suppose prevertebral abscess is there, so the most prominent symptom or sign will be the patient will have pale while movement of the neck, because vertebra will move, so patient will have the pain. So prevertebral abscess will present with a fever or the pain in the neck movements, whereas in the retropharyngeal abscess we can see a fullness in the posterior pharyngeal wall, plus lymph nodes may be enlarged in size. Now, this is a table which is comparing between the acute epiglottitis and the laryngotracheobronchitis, that is known as the Crohn's disease. We have already discussed in acute epiglottitis what is the X-ray sign. I told you it is a thumb sign. While in the Crohn's disease, what is the X-ray sign? The steeple sign. What do you mean by steeple sign? You all know stapler. So whenever we staple something like this, we staple, so what we'll do? Suppose this is a long tube. If I staple, so it will come close. So it will look like this. Okay. So it will narrow. So that airway will appear narrowed in between like this. Somebody has stapled it. Okay. So in laryngotracheobronchitis, the X-ray will show steeple sign. Now the structure involved in Crohn's disease, larynx, trachea and bronchus, everything is involved. Now what is the causative agent? In acute epiglottitis, the most common organism earlier would have been Haemophilus influenza B. Okay, it was back in 2000, in 90s or 2001, 2010, etc. But nowadays, the most common organism responsible for epiglottis infection is GABS, that is group A beta hemolytic streptococcus bacteria. And for the Crohn's disease, the most common causative agent still is the para-influenza virus, type 1 or type 2. Okay, so Crohn's disease is basically a viral disease. Acute epiglottitis is an bacterial disease. Acute epiglottitis, it has a sudden onset with a history of the fever, rapidly progress. That means patient will have toxic look, or patient will be suddenly very much ill in a span of 1 to 2 days. So it is that much severe because it will affect both the breathing and the eating pattern or the swallowing movements. Okay, and the fever, it may go up to the 40 degrees Celsius. Okay, so patient will have a high grade fever. Patient will also have the sore throat or dinophagia with a drooling of the saliva. I told you the reason, because patient will have pain while swallowing his or her own saliva, so there will be drooling of the saliva. Okay, cough. Cough is usually absent in epiglottitis because cough is a symptom which involves the lungs, or we can say bronchi, because in acute epiglottitis lungs are not involved, whereas in the Crohn's disease lungs are involved. So Crohn's disease will present as a cough with a barking seal-like sound. Barking seal-like sound. Okay. And hoarseness of voice, and now we all know usually hoarseness of voice is absent in acute epiglottitis, whereas in Crohn's disease hoarseness of voice will get present. Okay, dyspnea and stridor, very common in acute epiglottitis because at the entry level we got a blockage. Okay, so dyspnea and stridor will be there in acute epiglottitis, whereas in laryngotracheobronchitis mild symptoms will be there. It may happen but not so severe. Okay, now let's discuss about the prevertebral abscess or the retropharyngeal abscess. This is a diagram. First, try to understand what is the diagram. So this is the diagram. If I put my scope while opening the oral cavity, if I look into the mouth, so this is my diagram which is showing the posterior pharyngeal wall. Suppose this is my posterior pharyngeal wall, because this is the tonsils. These are the tonsils, and this seems to be my posterior pharyngeal wall. Now in posterior pharyngeal wall, there are multiple layers. The first layer is pharyngobasilar fascia. So this is my first layer. This is pharyngobasilar fascia. Okay, pharyngobasilar fascia. I can write properly with the help of the mouse. Anyway, just try to remember the first layer is pharyngobasilar fascia, and the next layer is buccopharyngeal fascia. Okay. Now the third layer comes is the alar fascia. What is this fascia? This is alar fascia. And the fourth layer is prevertebral fascia. So pharyngobasilar fascia is the first layer, buccopharyngeal fascia is the second layer, third layer is my alar fascia, and the fourth layer is prevertebral fascia. Okay, so the space, what do you mean by prevertebral space? Prevertebral space is the space beneath the prevertebral fascia. So I will demarcate this in the red color. So this is my prevertebral space. That means the space between the prevertebral fascia and the vertebra. Okay, so this is the space which is known as prevertebral space. Okay, so any abscess in this region will lead to the fever, plus there will be painful neck movements, and if meninges are involved somewhere, the spinal cord or the spinal cord meninges are involved, the patient may have the vomiting, fever and other meningeal signs. Okay, so this is my prevertebral fascia. Now this space, I'll turn into the blue. Now this space is known as alar space. Okay, so this is my alar space. That means space between the alar fascia and the prevertebral fascia. This is my prevertebral fascia, this is my alar fascia. So this space is known as alar space, or we can say that danger space. Why it is called danger space? Because this space extends up to the level of the mediastinum, or we can say the diaphragm. So any abscess or infection can directly go into the mediastinum and involve the major structures of the vessels of the body. So it is known as danger space. Now retropharyngeal space, retropharyngeal space is this space that is between the buccopharyngeal fascia and the alar fascia. So this is my retropharyngeal space shown in the green color. Okay, this retropharyngeal space, as you can see, it is divided by a septum into two parts. So these both spaces are known as space of Gillette. Space of Gillette. Everything is written, you don't have to write. So this is my retropharyngeal space between buccopharyngeal fascia and the alar fascia. And this space, the last space, this is my parapharyngeal space, comes like here. Okay, so I'll show. It's not very comfortable in this right now. Okay, now let's discuss retropharyngeal space of Gillette. Why it is called space of Gillette? Because by a septum it is divided into two parts. It's already been asked in 2013. So upper level is a base of skull where the retropharyngeal space start, and inferiorly it extend up to the level of the T4 vertebra. Okay, so anteriorly buccopharyngeal fascia, posteriorly alar fascia, we already discussed. This space consists of lymph node of Rouvier. So this again has been asked in the exam. Now we talk about the danger space. This is my danger space. So this danger space, it starts at the level of the base of skull and extend downwards at the level of the diaphragm. Okay, so I told you mediastinal structures are involved. That's why it is called as the danger space. Boundaries, anteriorly alar fascia and the posteriorly prevertebral fascia. Now comes the prevertebral space. I have already discussed. Above level is base of skull, lower level is T4 vertebra. So anteriorly it is bounded by the prevertebral fascia and posteriorly by the vertebra. Okay, now we talk about parapharyngeal space, just a little knowledge. It starts at the base of the skull and ends at the level of the hyoid bone. How it is important? Parapharyngeal space, it is the smallest space and the most common space which is infected by the tonsillitis. Don't get confused between the quinsy and the parapharyngeal abscess. Quinsy is not in space, okay? We can say it's space, but if we talk about the parapharyngeal, retropharyngeal spaces, so parapharyngeal space is the most common space which is being infected by the tonsillitis. And what are the boundaries? Medially, that means medially, midline, it is bounded by the buccopharyngeal fascia. Laterally, it is bounded by the medial pterygoid, mandible, masseter or the parotid. So this is the lateral limit where we can see the medial pterygoid, mandible is there, masseter muscle and the parotid gland is there. So laterally by this and medially by the buccopharyngeal fascia. It is generally by the styloid process divided into the two parts. The anterior part, it consists of maxillary artery and mandibular nerve, MM. Okay, so this is maxillary artery and mandibular nerve. Point to remember. And posteriorly it is having internal carotid artery, inferior jugular vein, 9th, 10th, 11th, 12th cranial nerve and the cervical sympathetic chain. These all you have to remember, very very important for the examination point. So parapharyngeal space abscess also we can say that somewhat like the danger space, because the space infection may infect the internal carotid artery, internal jugular vein, 9th to 10th cranial nerve, and symptoms will be somewhere related to the paresis of the cranial nerves. So this is a picture showing the diagram. See, this is a photo of the oral cavity where we can see this is my uvula and you can see a large abscess is there. This is not in quinsy. It is in parapharyngeal abscess which started because of the tonsillitis and involving the parapharyngeal space. As you can see, there is an edema of the soft palate completely. Uvula is also edematous and this edema is extending into the retromolar trigon. And what is the appearance of the patient? The patient will have a large mass in the neck. You can see my neck is so much swelling. So we can see at the submandibular area there is a edema or the swelling with the positive lymph nodes. Okay, so this is how the patient will present. And there will be prolapse of the tonsil or the tonsillar space or tonsillar fossa. Patient will also having the pain while opening and chewing movements because the retromolar trigon or this mandibular junction is involved. So the patient will have pain while chewing. Okay, and there will be edema as we have already discussed. So these all are the anterior compartments abscess. If the this abscess extend to the posterior compartment, that means may affect the cranial nerve. So the symptoms will be related to the 9th, 10th, 11th or 12th cranial nerve paresis or the pathology. Okay, so this is how the parapharyngeal abscess demonstrates.